Good afternoon, good morning, good night, whatever time zone you're calling in from. We are delighted to have you here. And welcome to a webinar sponsored by the National Center for Coverage Innovation and Families USA. I'm Stan Dorn. I'll be your host, moderator, and partial presenter this morning, afternoon, or evening, and we are just so delighted to have you here to talk about several time-sensitive opportunities to do some state policy advocacy to improve affordability of coverage in the individual market and increase the number of people who have health coverage. I'd like to begin by thanking our special guest today. Collin Baio, the Director of Policy and Communications of Health Action New Mexico, has been engaged in the first issue that we're going to talk about around health insurance assessments in New Mexico, and has already achieved some really important success and is moving forward for the future. John Pierre Cardenas, he's currently a health policy advisor on his own, and he was the policy director at the Maryland Health Benefits Exchange, where he played a leadership role on both of these issues that we're going to talk about today. And finally, I'm just so delighted to have Greg Fan, who is a nationally respected actuary, with us to help answer some of the tough questions that I'm expecting you all will come up with that none of the rest of us will be able to answer. So we are so delighted to have Greg's expertise on tap. I wanted to let everybody know how we're going to run the webinar today. We have everyone but the speakers on mute so that we can have a more coordinated conversation, but we really are hoping that people will send in questions and comments via the chat box, and we look forward to hearing and taking those questions. So can people see? Oh, well, let's see. We're moving a little ahead too quickly here. At this point, Collin or Greg or JP, can you see the slide that says Topical Overview?
Yes, good to go.
I can see it.
Excellent. All right. So here's what we're going to do today. We're going to talk about health insurance assessments, which is an opportunity for legislative advocacy this year. Then we're going to talk about metal-level premium alignment, which is primarily an opportunity for administrative advocacy, though potentially legislative as well this year, also time-sensitive, and then we look forward to taking your questions. To begin with, I'm going to provide just a little bit of background about the federal health insurance assessment. It's called under federal law the health insurance provider fee, and it was originally part of the suite of funding mechanisms enacted to pay for the Affordable Care Act coverage expansions. And it was suspended in 2017 and 2019 for 1 year, 1 year in 2017, another year in 2019. And during the latter year, two states, Delaware and Maryland, did something really interesting. They stepped forward and said, we are going to pass a substitute health insurance assessment, a state HIA, operating on insurers within our borders. We're going to take the money they would have sent to Washington, D.C., and we are going to bring it back to our state and use it to improve affordability of coverage in the individual market. And both of those states used the money for reinsurance, which lowered sticker price premiums. Now those 1 year suspensions have ended, and the fee is in effect. It is being charged. The federal government is expecting to get more than $15 billion this year using this fee. And you can see over on the right the hallmarks of New Year's celebration. Somebody's going to be celebrating on New Year's Day 2021, and it's up to you all on this call to make sure that the celebrants include families in your state. The reason why is January 1, 2021, the federal health insurance assessment will end permanently. It will be phased out as of that date. If a state acts now in 2020 to craft a state HIA, it can garner significant funds to help health insurance be more affordable for state residents. It can do the same thing that Maryland and Delaware did, take the money that the insurers of the state have been sending to Washington, D.C., bring it back inside the state, and use it for particular purposes to make insurance more affordable. That would not raise taxes, that would not raise the assessment level on insurers, it would keep the current level in place. It would prevent the insurance industry, many of the players of which are making a lot of money, from getting a tax windfall. And unlike the federal HIA, which goes to fund general federal operations, a state HIA can be targeted carefully to benefit consumers in the individual market, to benefit small employers, to benefit carriers, so it can be done in a way that it truly provides a win-win solution. But in order to prevent an increase in assessment, states have to act now during the current legislative sessions to enact a state HIA, which is one of the reasons we're doing this webinar right now and are so delighted to have so many of you on the call. Just a word or two about how the federal HIA machinery works. Each year, the IRS sets a total annual amount, more than $15 billion for 2020, which gets divided among the insurance carriers, the country's insurance carriers, in proportion to their national business. So it's not allocated state by state, it's allocated nationally, insurer by insurer. The markets that are affected include the individual market, the small group market, fully insured large group market, Medicaid managed care organizations, various kinds of Medicare plans, and federal employee and retiree health coverage. I'm not going to go into all the details that are laid out on this slide, but I will mention a couple of things. The main thing is that if you are a nonprofit insurer in general in your state, you only pay 50% of the assessment that a for-profit insurer pays. And if you are a nonprofit insurer that primarily serves Medicare, Medicaid, and CHIP, if 80% of your customers are Medicare, Medicaid, or CHIP, then you are exempt from the federal HIA. And so with that, that's a little word of background, and I'm going to turn it over to the amazing Collin Baio to fill you in on what their experiences have been in New Mexico and what they've learned. Collin, take it away.
Great. Thanks a bunch, Stan. Yeah, and we think that this is such an exciting opportunity for other states, so we really appreciate the opportunity to share our experience. So we did run a bill, House Bill 278, that would have established a healthcare affordability fund that would be funded by this health insurance assessment. Our legislative session ended about a week ago, and unfortunately we didn't get a hearing in the final committee, but conversations are continuing, and it looks like a really promising financing revenue stream for some of the priorities that state legislators and the governor have, and so we're continuing conversations on this. Could you move to the next slide, please? So I just wanted to start with the message that we were using in talking about this fee, because it's somewhat of a complex idea, but if there's a way to message this correctly, I think that you can help state lawmakers really wrap their heads around it. So generally, this is how we talked about it. A federal fee on health insurance companies is phasing out this year, giving the legislature the opportunity to collect a portion of that fee and invest it in programs that directly reduce healthcare costs for working families. House Bill 278 lowers the current rate paid by insurance companies under federal law by as much as 1%, while seamlessly shifting revenues from the federal government back to the state to help working families access critical services. This guarantees that consumers will benefit rather than hoping insurance companies do the right thing and share the savings. This bill will bring in $125 million in new recurring revenue to New Mexico, and according to the updated fiscal impact report, $99 million of that would go towards a new healthcare affordability fund, while $26 million would go towards supporting our general fund. The affordability fund can be used to reduce healthcare costs for state residents who don't qualify for Medicaid. And as our state economy improves and more people move up the economic ladder, the Affordability Fund can be used to make the transition from Medicaid to new forms of coverage easier for patients to navigate, to maintain the continuity of care, and to make New Mexicans more financially secure. And finally, if the lawsuit against the ACA succeeds and the whole law is struck down, the fund can be used as part of a strategy to maintain coverage for people who rely on the marketplace for their coverage. And so that's kind of the way that we've tried to synthesize this complex topic and make it a little bit easier for legislators to digest. So in terms of the policy, the first thing that we started thinking about when we decided we wanted to do some sort of version of the ACA's health insurance assessment was looking to see if we had an existing mechanism to use to pull down this money. And it turned out that we actually do have a 1% surtax on gross premiums that is structured in some important ways kind of similarly to what the Affordable Care Act version is. So this fee applies to fully insured major medical plans in group and individual markets that aren't self-insured. as well as Medicaid MCOs. And an important piece on the Medicaid MCOs is that you are able to draw in federal Medicaid matching dollars as long as you design the fee so that it fits with federal law. A few differences between the federal version and the state version. We exclude standalone nonprofit dental and vision plans, but do not do any exclusions for nonprofit major medical plans. And our state version does not exempt premiums below a certain threshold. And part of what we had to think about when we were designing this is the administrative complexity of our tax and revenue department having to collect a whole new fee versus piggybacking on something that already exists and navigating some of the trade-offs between those two. We figured it would be easiest for us, especially in a shorter budget-related session, to try to piggyback off something that already exists. Next slide, please. And so this is just kind of a comparison of the differences between the two fees, but you can see in some important ways they're similar. Being able to assess the fee on fully insured health plans, standalone vision and dental, and Medicaid MCOs provides a broad tax base and makes it so that we really can generate some significant revenue to put back into affordability initiatives. Next slide. So the way that we actually did this in our bill was changing New Mexico's current surtax from 1% to 3.25%, and that means it's a change of about 2.25%, and that allowed us to say both, we're shifting something that was being collected in state but by the federal government back into the state to put into healthcare affordability initiatives, but we could also message it as actually decreasing the tax burden on health insurance companies. As I mentioned before, this generates $125 million in new revenue, and the way that we structured it was so that the distribution of that revenue, most of it would go into a healthcare affordability fund that would be used primarily to reduce premiums, deductibles, out-of-pocket costs, and expand benefits for state residents. And then we also put $25 million of that into the general fund to support the overall general fund, but also to cover part of the state's expense for assessing the fee on Medicaid MCOs. Next slide, please. And so this is part of how we were messaging to legislators that actually we were reducing the current assessment at the federal level as we replace it. And so you can see that combined with our current surtax, the federal fee came to about 4% combined, and then what we're proposing, it would bring it to just 3.25% to really show that we're actually reducing that burden while also bringing in significant revenue. Next slide. New Mexico is somewhat unique among states because we do have pretty significant Medicaid enrollment and a generous federal match. So largely the revenue that we're pulling in from the assessment would be from the Medicaid program with a pretty small burden on some of the other markets. And of course, the investments would go right back into supporting coverage in the individual and potentially for the small group market as well. And so we could actually see improved risk pools by bringing more people into those forms of coverage who otherwise would remain uninsured. Next slide. And this is just a breakdown of the sources of revenue when you look at who pays. So the private market, it would only be about a quarter of the revenue brought in. The vast majority of the revenue would be through federal matching dollars, and then just 15% would be the state share. So the Affordability Fund and what it could go towards, I think one of the important pieces of context here is that we actually already have a study underway as well as some administrative planning for some healthcare options that the state has been working on for the last few years. Yeah, you all may know that we've been working on Medicaid buy-in and some other affordability initiatives. Last session, we were able to secure some state funding to do to do one last round of study, and then we were anticipating the following legislative session in 2021 would be when we would pass legislation to enact those programs. But since this came up this year, this opportunity to create this revenue stream, we wanted to make sure that we could capture those dollars while not kind of being overly prescriptive about how it gets used, so that once we could inform the programs based on the studies that are underway. And so what we did instead was just have some parameters around how the fund could be used. And so in our bill, we said it could only be used for marketplace plans and then coverage programs established by the Human Services Department that aren't part of the traditional Medicaid and CHIP programs. We also have a provision that says 60% of the annual expenditures of the fund have to go towards people who qualify for premium tax credits. And that would ensure that this would be a program that would be targeted to folks who whose income is under 400% of the poverty level, to make sure that this benefits that population. And then ensuring that it's subject to appropriation of the legislature and authorization of an affordability plan that the Human Services Department would present in the 2021 session. The next slide. So some of the programs that could be financed by the fund: state-funded premium and cost-sharing assistance, a basic health program, a coverage option for immigrants, age-based premium assistance to reduce costs for younger people and improve the risk pool, a marketplace coverage option with additional financial assistance, small business premium tax credits, reinsurance. There are a lot of different creative ways that states can reduce costs in the individual and small group markets, and this funding stream could really enable quite a few of them. And then I included a couple slides here just to put some of the messaging and the overall design forward. I think I covered it in some of the other slides, but I wanted to make sure that folks had this information and that it would be there in the slide deck once that's released to everybody. So we can move to the next one. And so here's just an overall overview of what was just covered. And again, this is one that's meant to be helpful for states that are kind of thinking about some of these policy design options and how New Mexico approached them. And with that, I think I can pass it off to JP.
Fantastic. Thank you so much, Collin. Really incredibly useful information. And now I'm excited to turn the conversation over to JP Cardenas.
Thank you, Stan, and good morning, afternoon, or evening, wherever you are. I am currently in beautiful Los Angeles, but I do hope that everybody is having a beautiful day today. I'm talking about some of the experience that we had in Maryland off of the two issues that I presented here, and I've also added some resources in my slides, so after they're shared, interested folks who are on the line can go ahead and access those resources. So we can go to the next slide, Stan, thank you. I'll cover three topics today. The first is the Maryland state-based health insurance premium assessment. The second will be the establishment of a state-based subsidy program, which allows some flexibility for the assessment to be allocated across affordability programs. And then the final thing that I'll be talking about today is Maryland silver loading outcomes. Go to the next slide. Thank you. So just to provide some background, the Maryland state-based health insurance premium assessment assesses all premiums that would have been subject to the federal fee under Section 9010 of the ACA, and where the state has statutory authority to do so. So if we think back in time to Collin's slide, there are certain lines of business for health risk that states don't have the authority to do so. The clearest one, of course, would be any self-funded employer health plan, for example, the Federal Employee Health Benefits Program, which, as you can imagine, in Maryland, given that we are bordering D.C., was an important thing to find out. So it's really important, I think, for states that are considering implementing this assessment what lines of business are included in the assessment, what lines are excluded, and then from a political perspective, what the total proportion of the assessment would be represented by any of those lines. So for example, if we're thinking back to New Mexico's, the vast majority of the assessment would be coming from Medicaid managed care organizations, while in a different state, for example, Maryland, only about half of the assessment is collected by Medicaid managed care associations, while larger portions are collected by private lines of business, either individual, small or large group. So it'll be important to think about the political ramifications based upon your unique state and where the revenue would be coming from with respect to lines. The purpose of the program, you can go back to it, Stan, actually. The purpose is a funding source for the state reinsurance program. The rate was 2.75% in 2019. An important note about 2019 is that when there was a moratorium for that year, so the Fed did not collect it at all, and so the state decided to recoup the entire amount, or the entire effective amount, which is 2.75%. After there was some uncertainty about whether or not the assessment would come back into place, from 2020 and onward, the state decided to do a 1% flat into perpetuity. That was mainly to create a level playing field across the different issuers in the marketplace, which is also something to think about. Some issuers are nonprofit, others are for-profit, and depending on the flexibility of your assessment, you may not be able to level the playing field or get it back to exactly how it was under Section 9010. And so 1% was the lowest common denominator for Maryland. The included lines in our assessment are individual, small group, and fully funded group lines. There are additional other ones, for example, standalone dental and vision, but they're really, really minute parts of the total collected value. Public programs that were included, the assessment structure meets Medicaid taxation rules, and it allows Maryland to access federal match via managed care organization payments. And those rules are, we can talk about them later, but they're broad-based, uniform, and hold harmless provision compliant. And the reason why this is something important to consider is if states are thinking about a 1332 waiver and collecting federal pass-through, of course the amount that the state gathers from the federal government is important with the total value of their state innovation waiver program. Collecting payments from managed care organizations would help enhance the total amount that the feds are paying compared with what the state is paying. And with respect to revenues, we estimated that it would collect $350 million in its first year. Go to the next slide. Thank you. So after we established the funding mechanism, we revisited whether the allocation of the funding for entirely to reinsurance was most efficacious. Right, so we decided as a state to propose legislation that would establish the state-based subsidy program, which is what it just says as the title, but there are important things that it allows the marketplace to do, the state-based marketplace. The first is that when compared with other funds, for example, New Mexico's program, this allocation of the funding is a bit more restrictive, so it's only certain affordability programs. The funding collected through the assessment can either be allocated through to the state reinsurance program or the state-based subsidy program. And another guideline must be that the allocated funding between the programs must maximize long-term affordability in the individual market. So that means you hire an actuary and you determine what the right sauce is with funding allocation to determine what allocation would be the best in the individual market. This is essentially a guideline that ensures effective utilization of the funding. And then with respect to flexibility, it allows the marketplace to establish and modify subsidy eligibility criteria via the regulatory process. So while we do have specific guidelines, the flexibility allows the exchange to be creative and innovative with its subsidy program. So for example, there could be a young adult subsidy program that could enhance specifically young adult premium assistance to encourage their enrollment in the individual market. Or it could be even more creative and leverage existing tax credit dynamics to create a geography-specific subsidy that could, for example, in Maryland with $11 million, you could eliminate the uninsured rate in western and southern parts of Maryland simply because of the marketplace dynamics there. So that flexibility is really important, and it allows the exchange to laser target certain populations that it wants to participate in the marketplace. Now, there are some important things to think about with respect to the assessment. Now, depending on what you utilize it for, the amount that you collect annually could be affected by marketplace performance, because lower premiums result in a lower assessment. Now, lower premiums, for example, coming through a reinsurance program, would lower the total amount of assessment that you collect. So that's important when you think about utilizing it for reinsurance. Now, that could, of course, be offset by increased enrollment, but past experience with reinsurance programs shows that it's not necessarily a driver of enrollment as other programs could be. So that's important to think about when you want to allocate funding by certain affordability programs. Also, one more thing, the individual market can be assessed the most compared with other lines and still have a decrease, especially if a state is considering becoming a state-based marketplace. Because when you stack health insurance assessment and the existing FFM, the federally facilitated market fees, that's about 6 to 6.5% that you could collect in this assessment that could then be reinvested in the individual market through a reinsurance program, for example. So that's important to consider. Now, on to Maryland silver loading outcomes. Now, in 2018, Maryland is one of the states that implemented silver loading to mitigate the cessation of cost sharing reduction payments. And in a nutshell, there were 3 huge outcomes. The first is that a doubled statewide receipt of premium tax credits, and this is largely due to its positioning of the silver, the on-exchange silver plans by about 10 to 14% higher than gold plans. That resulted in expanded access to zero cost in gold plans and increased enrollment in gold plans. And in fact, I think Maryland has the largest proportion of any state of enrollment in gold plans. And we put a simple marketplace QHP enrollment by meta level just to display the difference between over time about what this outcome led to. So in 2017, as you can see, for the gold meta level, only 5% of enrollment was in gold. In 2018, after silver loading, that jumped up to 20%. And then after the implementation of the reinsurance program, which further essentially magnified the difference between the gold and silver plans and premiums, that jumped up to 28%. And then in 20, that jumped up to 36%. So as you can see, the mix in Maryland's enrollment is skewed now to higher actuarial value plans compared with lower actuarial value plans back in 2017. So we believe that that's a really positive outcome in terms of lower deductibles and lower out-of-pocket costs. Now, states can definitely stack affordability programs, for example, establishing standardized plan design, standardized benefit design for gold or silver, if also the state did pretty enhanced silver loading. So you could kind of magnify the out-of-pocket cost reductions experienced by consumers if the state decides to do silver loading. So that's it. Thanks, Dan. And the last slide has my contact information, and I'm more than happy to help any state that has questions.
Thank you so much, JP. And I'll forgive you for lording it over the rest of us by talking about the weather in Los Angeles today. I'm going to pick up where JP left off in talking about this whole gold-silver issue. And I'm so grateful that we have Greg Fan on the call. He's a noted actuary who first has flagged this issue, which a lot of us really hadn't been paying much attention to, but it's really, really important. So I'm so excited to have him and to have you all on the call today because it's something we can do a lot about. So just a little bit of background. Most of you probably know that actuarial value is sort of a key term in thinking about the individual market actuarial value, AV, which is the percentage of costs of covered claims that the insurance company would pay for a standard population. Actuaries like Greg know what the characteristics are of a standard population and sort of run them through their paces and say, okay, the actuarial value of this set of deductibles, coinsurance, and copayments is X or Y or Z. So that's the structure of the exchange. So you have bronze plans with 60% actuarial value. It turns out to have, on a national average basis, about $6,500 deductible. In silver, the basic silver plan is 70% actuarial value, sort of the base. And if you are enrolled in a 70% AV silver plan, on average you have a $4,500 deductible. But people with incomes at or below 250% of poverty get cost-sharing reductions, CSRs, that raise the actuarial value of silver. But you could only use them in silver. So if you enroll in silver and you're between 200 and 250% of poverty, your CSR, your cost-sharing reduction, raises AV to 73%, which means your deductible comes down, a bit, $4,500 to $3,300 on average. If your income is below 200% of poverty, then the improved access to care becomes even more significant. So between 150 and 200% of the poverty level, you get an 87% AV plan. On average, that's a $760 deductible. And if you're below 150% of poverty, you get a 94% actuarial value plan in silver, which has an average deductible of about $210, as you can see. Now, if you enroll in gold, the only actuarial value there is 80%, and if you enroll in platinum, the actuarial value there is 28%. And for purposes of our conversation, it's worth noting that gold deductible, $1,500, what JP was talking about in Maryland is really extraordinary. All kinds of people who in every other state would be enrolled in base silver, $4,500 deductible, or near base silver, 73% AV, $3,300 deductible, instead are enrolled in a plan with a $1,500 deductible. Still not ideal for many of our perspectives, but really a very significant improvement in affordability. So let's circle back and talk about this issue of silver loading that JP talked about. Silver premiums pay for more than they used to. So at the start of the ACA, premiums in silver paid for that 70% base silver plan. If you were enrolled in the CSR variant, the insurance company would bill the federal government for a separate stream of federal CSR payments. So the premiums didn't have to cover those extra costs. But Donald Trump, in late 2017, eliminated the federal CSR payment stream. So now, starting with the full plan year of 2018, premiums must cover all claims, not just the 70% baseline silver, but also the 73%, 87%, and 94% silver. So what that means, we know from the national data we get from the federal government that if you look at silver marketplace enrollees across the country, more than 40% of them are in 94% actuarial value silver. Almost 30% are in 87% AV silver. And if you put it all together, it turns out that silver plans in the United States in QHPs are now paying for 85% of covered claims. That's an effective actuarial value of 85%, which is higher than gold. And this is where the metal level mismatch that motivates this second half of our conversation comes in. Based on true actuarial value, the percentage of claims that a plan would be expected to pay for a standard population, silver all around the United States ought to be more expensive than gold. Silver ought to be 42% higher than bronze and 33%, and gold should be only 33% higher than bronze. Instead, as you can see, we have silver that's lower than gold on average in the United States. Now, the question is, does this really matter? If you're a consumer advocate, you got a lot of things on your plate, should you care about this? Well, maybe so. But in order to understand why some of us think it's important, we have to dive through the looking glass of silver QHPs, which are the weirdest premiums in the universe. They are the only, like in general, if a premium goes up, the consumer's costs go up. If a premium goes down, the consumer costs go down. Pretty straightforward, right? Not so with silver QHPs, unique in the entire menagerie of insurance types: property, casualty, life, disability, you name it, liability. Silver QHP premiums determine the value of assistance that lots and lots of people, not just the silver premium enrollees, lots of people get from the federal tax code. And so what that means is if a silver QHP premium goes up, people can get more help from the tax code in buying insurance, which means that their premiums go down. So this is why it's this strange looking glass phenomenon where when it comes to silver QHP premiums, higher premiums can mean lower costs for some consumers and vice versa. So let's talk about the technicalities of how this works to some degree. The way the premium tax credit works is that you qualify with income at or below 400% of poverty. You have to meet certain other requirements as well. But based on your income level, you have a certain need-based premium payment that you are expected to come up with if you enroll in a benchmark plan, which is the second lowest cost silver plan. So your premium tax credit amount is your benchmark premium, the cost in your locality for somebody of your age, the second lowest cost silver plan minus your income-based amount. If you pick a plan that's higher than the benchmark, your premium tax credit is the exact same amount, so you have to pay dollar for dollar the difference in price. If you pick a cheaper plan, your premium tax credit is the same, so you achieve a savings dollar for dollar. So let's provide an example. This is hard to wrap your head around certainly for me and maybe for others as well on the call. So let's take two people, Francis and Franklin, next-door neighbors, each 40 years old, single adults. They each earn $31,225 a year and qualify for premium tax credits. Francis enrolls in her benchmark plan, the second lowest cost silver plan, and that plan is $462. Her income-based amount at that income level, $31,000 a year, is $216. That's what she has to pay. So therefore, her premium tax credit is $246 a month, the benchmark plan minus her income-based amount. Now Franklin, her next-door neighbor, enrolls in bronze. He has the exact same premium tax credit amount as Francis because he's at the same income level, the same geographic area, the same benchmark premium, but he picks a $331 bronze premium plan, the lowest cost bronze plan, and he only pays $85. Why? He has a $331 sticker price premium minus the $246 premium tax credit. Franklin winds up spending $85. Now what happens in their neighborhood if sticker price premiums drop by 25%? Now the benchmark silver plan is $347 instead of $462, and the lowest cost bronze is $248 instead of $331. Well, everybody ought to be throwing a party, right? Not really. Let's look at what happens. Frances, enrolled in the benchmark plan, pays the exact same amount. Her amount is based entirely on income. So the lower sticker price premium just means her premium tax credit goes down. So it's only $131 instead of the $246 it used to be. The benchmark is now $347. We subtract her $216 consumer payment, $131 PTC. Uncle Sam saves, Francis does not. And Franklin actually has to spend more. Why is this? He has the same PTC as Francis, same income, same geographic area. Yes, his bronze premium went down, but not by as much as the premium tax credit. So now he's got a $248 bronze plan. He's got his $131 PTC, and he has to pay $117. He used to be able to pay $85 for this plan. Now it's $117. Why? Because the silver plan became cheaper, and therefore he spends more. We are beyond the looking glass. And so because we are beyond the looking glass, it's essential to take into account the weirdness of silver. Whenever you think about policy in the individual market, you can use it to help consumers or to harm them inadvertently. So suppose in 2019, instead of having the metal level premiums misaligned, suppose it was aligned. Well, what that would mean is that the premiums would be what you see right here on this slide. Instead of $340 in bronze, you'd have $331. Instead of $454 in silver, you'd have $469. Instead of $516 in gold, you'd have $442. So gold would be cheaper than silver, and bronze would be cheaper. The margin between bronze and silver would be greater. What would happen? Well, the paper that we sent you, the draft paper, which we're hoping to publish shortly, goes through state by state and describes what the effects are if we fix these premiums. I've just given you the national premiums. We've calculated the similar premiums in 37 states for which we have data and where we think there's a real misalignment right now. So what would happen? Well, nationally, you have 1.3 million people who are currently enrolled in pretty high deductible silver, $4,500, $3,300, who could switch to gold with a $1,500 deductible and save money on their premiums, 1.3 million people. You have almost 800,000 people currently enrolled in Gold who would see their premiums go down at least $43 a month. You have 1.5 million people in Bronze who don't get free Bronze today. They would save $39 a month on average. Now, I think most of you probably know there's 4.4 million people, the Kaiser Family Foundation tells us, in these 37 states who are offered, they're uninsured and they have free Bronze available to them, but they're not signed up. Their premium tax credit amount is equal to or greater than their Bronze premium. That number would nearly double. It would go from 4.4 million to 8 million uninsured people offered free Bronze. Now, there is a downside, of course. Almost 240,000 people who now buy Silver qualified health plans in the exchange without a premium tax credit, their sticker price premium would go up. They would pay more, averaging $17 a month. Now, it's not necessarily the end of the world for them. They could move to Gold and get much higher value coverage by spending another $23 compared to what they bought with a non-aligned premium, and many of them would consider themselves better off on balance because of the much lower deductible they would have. With the realignment that we're talking about, much more affordable coverage for millions of people, lots of young and healthy adults currently uninsured would sign up for coverage, improving the risk pool, lowering sticker price premiums, and so a lot of these folks who it appears from our analysis would pay more, in fact, would wind up being charged less. And most states nowadays will let people, are encouraging carriers to offer Silver plans only off the marketplace. Certain plans on, certain plans off. That way, the plans that are offered only off the marketplace do not have to raise their premiums a nickel for CSRs because they do not cover CSRs. So on net, when you look at all these vectors together, it turns out that consumers would save $1.7 billion if premiums were realigned. Or put differently, consumers in the individual market are now paying $1.7 billion too much because premiums are not aligned with value. Now, why is it that premiums are so misaligned? Well, one piece of it, of course, is there's aggressive underpricing of Silver to get market share. We know about half of the individual market in the exchange consists of people under 200% of poverty, and if you are the carrier who offers the lowest price Silver plan, you're going to pick up the lion's share of these folks. They're going to want to enroll in Silver in many cases to get that low deductible coverage. Very price sensitive, so $10, $20 a month less, you're going to get a lot of people running to your door. So plans that are interested in serving that market segment have an incentive to underprice Silver aggressively and make up the difference by raising charges at other metal levels. But there's something else going on that I think goes really to the heart of the ACA's insurance reforms, the protection of people with pre-existing conditions and the prohibition of discrimination. So if insurance those anti-discrimination rules mean, what we talked about earlier, when you charge premiums, you shouldn't be looking at the risk level of that individual consumer signing up for coverage. You should not be looking at the risk level of the people enrolled in a particular plan. You should be looking market-wide at what that risk level is. And if all carriers did that, then the carriers would make extra money on Silver enrollees and lose money on everybody else. Why is that? Because low income is associated, all else equal, with less utilization. Silver plans have the majority of low-income folks who are in the market, people below 200% of poverty because of that high AB Silver. And so what that means is you as a carrier, you have to charge that same Silver premium across the board for everybody. It includes a lot of low-income people, and those costs are going to be less than the average other person in the exchange. So what that means is that if you serve a lot of Silver folks, you'll make a little extra money because they're a more profitable group. If you have other metal levels and you're not serving so many low-income people, your costs are going to be a little higher than what you can charge. So what this means, among other things, is it means that insurance companies have an incentive to come out ahead, not by offering good service at low prices, which was the goal of these ACA insurance reforms, but by avoiding unprofitable risk and seeking profitable risk. It also means that if you have an individual insurance market without a strong regulatory hand, carriers are going to move as best they can. They're going to scooch their premiums down or up towards cost. So with Silver, if you've got a bunch of people competing, they're all going to scooch down towards the average cost of Silver. They're all going to scooch up their Gold premiums towards the average cost of Gold. And the problem is we don't have risk adjustment is supposed to fill in the difference between the risk level, but risk adjustment does not take income into account. So in thinking about why this is happening, imagine, for example, that we had that cancer was not taken into account by risk adjustment. Today, if one carrier has a lot of people with a cancer diagnosis, that carrier gets extra money for risk insurance to cover those costs. If another carrier doesn't have anybody who has cancer, they have to pay into the risk adjustment system as a result. Suppose that wasn't in effect and we just had a risk adjustment system that didn't include cancer. What that would mean is if you serve a segment of the market as an insurance company with a lot of non-cancer people, you'll make money. If you pick up a segment of the market with a lot of cancer people, you're going to lose money. And if it's a competitive market and the regulators looking the other way, then some plans serve cancer people and others serve non-cancer people. The premiums for the non-cancer people are going to scooch down. The premiums for the cancer people are going to scooch up, and that is what we are seeing with silver, gold, and other levels. So I think that is really one important thing that is going on. So why is it that insurance companies are being allowed to get away with violating what is really a core ACA requirement? Well, one piece of it is that regulators are responsible for the whole panoply of insurance products. The list I gave you earlier: property, life, casualty, liability, blah, 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 group insurance, individual health insurance. And they may not realize how weird and unique silver is, and they may not realize that unlike every other insurance premium they regulate, this is one where lower premiums can hurt consumers rather than help them. So they may not be focused on that in the way that we would like them to be. Another factor could be that a lot of regulators were upset, understandably so, when insurance companies pulled out of individual markets and it made them look bad as a regulator. Now, thank God we have carriers who are back in. Some of them are worried that if they push down too hard, if they regulate too much, carriers may flee for the hills. That may be a factor. Another factor is publicity. Though, unfortunately, the media often looks to silver QHP premiums as the single metric for affordability of coverage. So what that means is really consumers might be better off with that higher premium, but it would make you look bad as a regulator. So that's got to be back there on the back of people's minds, no matter how well motivated they are. And of course, a lot of regulators, depending on the state, don't aggressively regulate their insurance companies. So what should regulators do? Or put differently, what should advocates be urging regulators to do in looking forward to the 2021 plan year? And the reason why we pushed forward with this webinar on relatively little notice is that work needs to begin now if we're going to try, well, it actually would have been good to begin a while ago, to try to shape the 2021 premium. So it seems to us, and again, I want to thank Greg for his guidance on all of this, that there's a couple of things to encourage regulators to do. One is to look at the induced demand factor. What the heck am I talking about there? So when an actuary develops a price for an insurance company, it doesn't just look at an insurance product, just to say, okay, this one's 70% of the claim, this one's 80%, this one's 90%, same claims, right? Standardized population. No, they say if there's less cost sharing, there's going to be more demand, induced demand, more utilization. So you have to take into account both that a high actuarial value plan is paying a high percentage of claims and that there are more claims in total. And so one of the ways that insurance carriers have been doing this, have been avoiding their legal requirements and scooching up gold and scooching down silver, is they've been playing games with induced demand. And they've been saying that even though gold covers a smaller percentage of costs now than silver, they're going to assume that there's a 30% increase in demand for gold and a 2% increase in induced demand for silver. That's only a slight exaggeration from what some carriers are saying. Well, an insurance regulator, even if you're not, don't believe in regulation per se, you should be saying to your carriers, if gold is covering fewer claims than silver as a percentage of total incurred claims for standard population, you have to be assuming less induced demand. In other words, more cost sharing means less demand, less cost sharing means more demand. You shouldn't base it on whether it's called gold or silver. You should base it on the percentage of claims that are covered. So in fact, that's already what the state of Virginia does. They tell their regulators, you can't just make up whatever induced demand, they tell their insurers, you cannot make up whatever induced demand factors you want. You have to follow the federal government's induced demand factors that they use for risk adjustment purposes. So that's probably the most important thing, rational induced demand. The second is for regulators to say to the insurance companies, you have to assume rational behavior by consumers. If you're going to look at what silver premiums are, you have to assume that all or almost all of the individual consumers are high AV folks, people below 200% of poverty, for whom it makes sense to enroll, because other folks are going to be paying, 70% plus premiums, 80 premiums, and getting only 70% value. So those two questions are really critically important. And then the final piece is a sort of more philosophical one, or sort of what to focus on, I guess a mindfulness thing, that whatever level of scrutiny is used in a state, the highest level of scrutiny needs to apply to those strange silver QHPs to make sure that carriers don't underprice silver. So with that, I'll just note that we have these reports that we've made available to a lot of you. Anybody who wants them, send me an email, and we will send them to you. Send them your way, and use them as best you can. So now we're going to turn it over to you, questions and answers, and please use the chat box function to send in questions. And so we're going to begin with a question that's directed at Collin. Collin, this questionnaire notes that the New Mexico legislative session is over. Stan talked about how it's really important to get something done this legislative session. Are you giving up now, or is this something you think you can actually take on in the future?
Yeah, thanks for that question. A key part of our message during the session was that we've got to get this done this year, and the main reason was that that if we let this time lapse, then insurance companies are going to basically profit off of the fact that the fee is built into the 2020 rates, but they don't owe it to the federal government. So that was why we were really talking about it as something that had to get done this year. But because we made such a strong case and showed that we could leverage significant federal resources, it's something that continues to be on the table, and that state legislators and other state officials have interest in. And so we're continuing conversations about this, and as of right now are planning to try to introduce something similar to what was introduced this year during the 2021 session. And by then we will have all the details of a comprehensive affordability plan worked out so that we can make that more concrete ask of legislators. So I guess the short answer to that is no, it's not. We're not taking it off the table. We're continuing conversations about this and think it's a really smart strategy.
That's great. Thank you, Collin. Here's a question for Greg. Greg, a lot of the folks on the call are consumer advocates who may not have a long history with state insurance regulators. What advice would you give them about how to make the most effective possible approach to state insurance regulators talking about this whole issue of metal price premiums?
Sure. So I think every state is different in where they are. So I think understanding sort of the dynamics within a state would be important. So you're probably going to want to talk to an actuary either on staff or a consultant to really do a landscape review of the carriers in the market, what their premiums are, what their rate levels are, and then it really gets down to talking about the things that you talked about in enforcing, appropriate metal level sloping, rational assumptions of what consumers will do, but I think understanding the dynamics and understanding the market and who the players are is the first step that each state would need to do.
That's great. Thank you, Greg. A question for that's come in from Vermont. Has any state considered extending the HIA tax, to the portion of, this is really interesting, the portion of in-state insurer profits that are from administrative services, I assume that's self-insured third-party administrators, to avoid incentives for employers to self-insure. In other words, if you just tax fully insured group coverage, then an employer might say, to heck with it, we're going to go and self-insure. So does it make sense to extend the tax to self-insured third-party administrators as well? Great question. Any answer from either JP? Why don't we start with JP and then Collin?
Sure, thanks. That's a great question. I think from a political perspective, rather from a public policy perspective, I think it makes a lot of sense, right? Because you don't want to create counter incentives for fully insured groups to move over to self-insured groups to avoid the assessment. But it's also important to note that from a political perspective, self-insured plans do not participate in the existing HIA. And so if, assuming all things level, and there is a seamless transition of the total amount of assessment, you would not expect individual employer behavior to be different. So as long as you keep the assessment the same as it was under the federal to a certain extent, you can kind of have similar expectations about what the movement would be in the market from fully insured group to, for example, self-insured group. Another important thing to consider is if it's allowable under ERISA. I know a lot of states do that. A lot of states have contemplated that, but there have always been issues with interfering with ERISA. So.
Great, thank you. A question for Collin. You noted the possibility of using some of this money for small group subsidies, like for tax credits for small employers. Why would you think about doing that? What advantage would that offer? Are there any political risks that would push back against?
No, I think it's actually one of the ways to make this a little bit more palatable for small businesses, because we did get some pushback from small business groups saying, look, we don't see necessarily a guarantee of this actually helping small businesses. One thing we wanted to note for those folks is that only 23% of small businesses in the state actually offer health insurance, which means that the workers for those small businesses in many ways are either relying on Medicaid or the health insurance exchange. And so for the vast majority of small businesses, this would be helpful. But if we wanted to look at either holding small businesses harmless to make sure that they donate, get some of the savings that might otherwise be coming to them if insurers were to pass the savings along, we could really make sure that it's a guarantee that happens rather than just hoping that the carriers do it. But I think that's certainly something that states, that advocates should think about, whether that's the right way to do this, or if you could use this as an incentive for more small businesses to move employees onto the exchange if that's a goal that you might have.
That's great. Thank you. One question for JP. Do you have thoughts about? I know in Maryland you have a 1% lowest common denominator rate, so that neither the nonprofit carriers nor the for-profit carriers need to pay more. Is there any other approach the state could take to navigating that complexity, where under the federal HIA, nonprofits pay half of what for-profits do?
That's a great question. I think that, frankly, the 1% right now is actually not the lowest common denominator, which is important for Maryland to consider. With the repeal of the federal HIA, the lowest amount an entity was paying is actually 2%. If you stack the 1% assessment from the state and the 1% assessment that the feds were doing on nonprofits, stacking them together, the true pass-through for seamless transition would actually be 2%. So states are issuers in Maryland are still experiencing essentially a tax cut of about 1% if you're a nonprofit, and closer to 3% if you're a for-profit. So I do think that Maryland should consider increasing the rate to 2%. With respect to kind of cleaving things, we wanted to be sure that we didn't run afoul of Medicaid managed care rules. And we know that there's a lot of movement in the regulatory space there. And so kind of touching that we didn't want to disturb kind of the status quo of the assessment. So I don't believe there's going to be much movement there.
Okay, that's great. Well, folks, we've reached the end of our hour. I want to thank our speakers, our guest speakers. I also want to give a special shout out to Hannah Marcus, who has been behind the scenes making everything happen, and thank all of you from around the country who participated. I just want to remind folks that we have these draft papers that we've sent around. If you didn't get a copy for some reason, send us an email, Stan Dorn, sdorn@familiesusa.org. We'll get them out to you. If you have comments about those draft papers before we finalize them, we'd love to hear them. If you want technical assistance, we are here, and we are friends with some of the amazing people you've heard on the call as well as others. And these are exciting opportunities in dark times, and we are really privileged collectively as a community to have a chance to work on this. And we are so honored to work with you and look forward to doing so in the weeks and months ahead. Thank you so much, everybody, and have a wonderful rest of the day.